Well, good day, everyone, and welcome to the Canadian Cochrane Centre's Winter 2010 Research Webinar Series. My name is Adrienne Stevens, and I am the Education Coordinator here at the Centre. I hope you're having a great day. Before we get started, I just want to thank a few folks, those being the Canadian Institutes of Health Research, 6 of their research institutes, as well as to the Canadian Agency for Drugs and Technologies in Health for their financial support during our current funding period. Thank you to you both. And as well, we would like to thank the Pan American Health Organization, that is the regional office of the WHO, to their Research Promotion and Development Division for providing access to their Illuminate license to be able to conduct webinars such as the one today. Thank you to PAHO. And I just want to remind you that registration is currently open for the 8th Canadian Cochrane Symposium, which will take place here in the nation's capital in Ottawa, Canada. The symposium will be taking place the 19th and 20th of May, and as well we have some pre-symposium training workshops that we're offering on the 17th and 18th. Abstracts are due tomorrow, February 12th, so we encourage you to participate, and we look forward to seeing you there. I just want to orient you a bit to Illuminate before we get started. So as you will probably see, your name appears in the participants window in the top left hand portion of the interface. So you will see your name as well as others who are participating. If you wish to ask a question during the session, and I ask that you hold your questions until Dr. Schünemann is ready to take them from you throughout the session, and he will cue you as to when you can ask questions. All you have to do is press the hand with the arrow. There's a button that is located under the participant screen to the left. All you have to do is simply press on that, and that will form a queue for questions for Dr. Schünemann to answer. If you wish to communicate using the emoticons during today's session, next to the hand you'll see there's a happy face, some applause, so please feel free to use that during the session. As well, today we'll be conducting a poll, and as you can see under the participant window there are options A through C, and so when it comes time to conduct the poll, Dr. Schünemann will instruct you at that point as well. All you simply do is make your selection there under the participant window. We've set the settings such that you won't be able to see each other's answers, so you won't see your answer appear in the window, but you will see it depressed underneath the participant window there. So once you make your selection, that's great. We've received it, and we will then publish the aggregate results to the whiteboard, at the appropriate time. As well, in the chat room, if you've joined us and you do not have a microphone and you wish to send a question or a message to Dr. Schünemann or myself, we will see that come through the window. Great. So before we get started, just to remind you of the format of the webinar, we've set it up such that it's one audio activated at a time. So if you do want to ask a question, then when you raise your hand and Dr. Schünemann will instruct you when you can ask your question, he will press his audio button, which then releases the ability for you to then activate yours. So you simply press the button, ask your question, and please don't forget to press the button again so that he can come on to answer your question. Great. So without further ado, I am pleased to introduce you to Dr. Holger Schünemann. He is the chair of the Department of Clinical Epidemiology and Biostatistics at McMaster University in Hamilton, Canada. And of course, for you being involved in the evidence-based medicine arena, you will know that that's where it was birthed. He co-convenes the Applicability and Recommendations Methods Group of the Cochrane Collaboration and is a co-chair of the GRADE Working Group. His current academic interest focuses on improving methods and collaboration in evidence syntheses and guideline development. He has developed guidelines with a variety of organizations, including the WHO, the World Allergy Organization, and the American Thoracic Society, and others, and has also supported regional and local agencies in guideline development projects. He has authored over 300 peer-reviewed publications, books, and book chapters, many of them focusing on guideline methodology. His other research focuses on systematic review methods, study design, information presentation, quality quality of life research methodology, and respiratory medicine. As inaugural documents editor of the American Thoracic Society, an internationally leading professional society for respiratory, critical care, and sleep medicine, he is responsible for guideline and other official document development for the ATS. He is editor-in-chief of the Health and Quality of Life Outcomes, associate editor of the American College of Physicians Journal Club, and co-chair methodology of the American College of Chest Physicians Conference on Antithrombotic and Thrombolytic Therapy Evidence-Based Guidelines. He has his medical degree from Hanover, Germany, and has also a PhD in Preventive Medicine, Public Health, and Internal Medicine at the Medical School of Hanover, Germany, and at the State University of New York at Buffalo. Holger, I am very pleased to have you with us today. So to all of you, please join me in welcoming Holger to the floor.
Well, thank you, Adrienne. I hope everybody can hear me well. I will ask Adrienne to show me a smiley face, and she did so. So thank you very much for the introduction. I should have sent you a shorter text, I guess. I didn't realize that you were going to read this all out. So thanks for that. Yeah, we will. I'm very pleased to be able to join you today and speak to you about grading the quality of evidence, grading evidence in general. I welcome you to this session, and in regards to just some housekeeping issues, I would suggest that you do ask questions after individual sections. There will be some voting exercises involved, but you will see when a section is actually completed. So, and I will also give you chances or opportunities to ask these questions by reminding you. Now, in regards to the voting, we can speak about that when this actually will come up. But let me go on. What is today's session about? It is really about evaluating the quality of evidence for a given healthcare question. What do we mean by quality of evidence? Well, in the context of a systematic review, the quality of evidence, in our view, reflects the extent to which we are confident that an estimate of effect is correct, and that is true for individual outcomes in particular. Now, the way that we look at quality of evidence is very much reflected in this cartoon. It reflects the magnitude of an effect and the confidence in the evidence. One meteorologist saying to the other, I figure there's a 40% chance of showers and a 10% chance we know what we are talking about. So there is some certain degree in the actual estimate of the effect, which is a 10% chance of a 40% chance of showers, and about 10% certainty that the meteorologists know what they are speaking about, such as poorly done observational studies would convey. Okay, so in regards to why we are interested in speaking about assessing the quality of evidence and grade in particular, this is because the Cochrane collaboration, in addition to many, many other organizations such as the WHO, the National Institute of Health and Clinical Excellence in the UK, several large professional societies in the US, as well as most recently, for instance, the Canadian Cardiovascular Society, are using this approach. But we are here to speak about the Cochrane collaboration, and this session actually will focus only on grading. So we will go right into the grading exercise and the grading presentation, with the assumption that many of you have seen other presentations before. And once again, I just remind you, if you do have a question that is related to understanding rather than the sections that I was speaking about, understanding about grade, you can raise your arm now. In grade, we distinguish 4 categories of quality of evidence. And it starts with high quality, goes to moderate, low, and very low quality, expressed here by the signs that the collaboration uses in its summary of findings tables. Now, we realize, obviously, that there's a continuum in terms of quality These categories actually serve to convey messages, to facilitate communication in particular, and because it is extremely challenging to express quality on a continuum. But having said all this, randomized controlled trials typically start as high quality, and observational studies start as low quality on this 4-category level. There are 5 factors that can lower the quality of evidence and therefore our confidence that an estimate of effect is correct. And there are, first of all, limitations in the detailed design or execution of studies, and this very much relates to the Cochrane risk of bias criteria, inconsistency or heterogeneity in study results, indirectness, and that very much relates to the actual question that is being asked in the PICO format, population intervention comparison and outcomes, and is related to applicability. And the 4th criterion is imprecision, which very much depends on the number of events and confidence intervals. And the 5th is publication bias. Now, in the upcoming slides, I will speak about these factors in detail, and this is how this talk is actually going to be presented in sections about quality criteria. There are 3 factors that can increase the quality of evidence in our confidence that estimates of effect or effects are actually correct. First, a large magnitude of an effect. Second, a more complicated criterion that I will spend little time on. It mostly applies to observational studies. That is, all plausible confounding may be working to reduce a demonstrated effect or increase the effect if no effect was observed. And the 3rd criterion is a dose-response gradient. You should note that the factors that increase the quality of evidence are likely to apply only when starting with observational studies. Now, let me start by speaking about the design and execution and limitations in design and execution and the risk of bias criteria. These are our typical criteria that most of us will be familiar with that would potentially lead to downgrading the quality of evidence. So we're speaking about these 5 factors now. Limitations in the design and execution, such as a lack of concealment, if the intention to treat principle is violated, if there's inadequate blinding, if there's a large loss to follow up. Newer criteria such as early stopping for benefits that are observed and selective outcome reporting are all factors that would lead us to limit our confidence in an estimate of an effect and could lead to downgrading the quality of evidence. Now, we'll give you an example. This is an example from a Cochrane review by Cates and Cates from 2008, and it has to do with the outcome serious adverse events in patients who are treated with salmeterol for chronic asthma. And as you see on the right-hand side, this is one of the new risk of bias tables in Cochrane reviews listing, and I will make this a little bit larger on the next slide, listing 30 individual studies and an assessment of the risk of bias in these 30 individual studies. Now you see on the right-hand side, where I have the pointer now, you have these assessments done by the reviewers in regards to whether they believe there is important risk of bias, and you see that for some of these studies there is concern about selective outcome reporting for these adverse events indicated by the red dots on the right-hand side actually. Now, the risk of bias table is one way of expressing this. This is a graphical representation of what we've seen for these 30 studies, and what it shows is a percentage of studies that appropriately concealed allocation, that appropriately blinded individuals or patients and outcome assessors, and those that were free or not free of selective outcome reporting. it becomes very clear that both for the reviewer as well as those using the review, an overall judgment is required, and that an assessment needs to be done. Now, once again, there were 30 studies here. They looked at the outcome of adverse events, and this graph represents, in a simplified version, because there's no weighting of the studies, in a simplified version, the potential risk of bias that may be inherent here. On the next slide, I will ask you to help me determine whether you believe that this risk of bias, I've explained the question to you, whether this risk of bias is of significant concern, of enough concern to possibly to limit your confidence in the estimate of any effect that will be observed, and that might lead you to downgrading the quality of evidence. You will see on the left-hand side of your screen the opportunity to vote. The letters A, B, and C are shown next to this little door, and I would ask you now to vote if you are significantly concerned about the risk of bias here. Vote with an A, with a B if you're not concerned, and C if you don't know what I'm talking about or if you're undecided. I'll give you a little chance here, a little time. Okay, I ask you all to vote in order to move on. Many of you have, I can see that. Okay, very good. We'll stop here. And as you've seen, those of you who have voted, the majority, by far the majority, actually said, well, you would be concerned about the risk of bias here. I suspect that for the most part this was true because there was a selective, it looked like there was selective outcome reporting. I will come back to this issue after I've shown you the next slide. Thank you very much for the actual voting. And the next slide shows you another example, actually an example from a different study, different systematic review, apologies. And here we are looking at the risk of dying, so mortality in patients with advanced cancer who are receiving anticoagulation therapy. We did a systematic review looking at 5 randomized controlled trials that were all fairly large, and we did an assessment. We completed an assessment in regards to the risk of bias, and you see the risk of bias table here for these 5 studies. And we were more conscientious in that regard because we actually looked at 5 quality criteria, 5 criteria for the risk of bias. So same principle here. I would ask you once again to provide me with a vote of in regards to who of you believes that the risk of bias, I will go back in 1 second, is of significant concern. If yes, please vote with A. If no, please vote with B. Okay, and I will ask Adrian to publish the results, and they should be there in 1 second. So what you see here is that about half of you thought that there was an important concern about the risk of bias. Half of you thought there may be no concern about the potential risk of bias, and some of you were undecided about this. Some of you didn't vote. So the reason for this exercise is for you to understand that judgments are clearly involved here. Most of you will be trained in research methods. Most of you will be trained in conducting systematic reviews, and at the same time you have legitimate disagreement. And that is once again related to that there are no clear-cut rules for when you're starting to be really concerned about a certain risk of bias and when not. And what this particular framework can do for you is to say, okay, we were concerned about the risk of bias, and here are the main reasons. I will open this up for a brief discussion. Just please either raise your hand or type in a brief comment to all, so that we can actually see your questions that relate to this particular issue of the detailed study design and execution and risk of bias. Okay, one question was asked. Please go ahead and ask. Okay, the question is, there are several studies with a lack of information, and I will reflect on that. Very good question. The question marks actually indicate that the reviewers were uncertain about or could not obtain information about this individual quality criterion. So there are a couple of ways of determining whether one should be concerned about the risk of bias, and this will become more clear. So first of all, judgments are involved. The next point is, are the concerns in the individual studies important enough that they would actually change the results? So one way to explore of whether a particular study, such as the first study listed here, the study by Altenbest, where there are 4 question marks, whether these studies actually importantly moderate or change the results that are obtained. One can do this through sensitivity analysis and say, well, even in the study where there is a questionable risk of bias, even if the study would not contribute to the results would be the same, so that I am not that concerned about this study that has questionable quality criteria. So that is one of the potential ways of dealing with this issue. You will always, if you can, contact the authors. Obviously, have these question marks there. I will ask now Mohammed Ansari to ask a question. Could you please type your question? That would be preferable, perhaps.
Holger, perhaps while Mohammed sent his question through, oh, it's come through already, so you can go ahead. Sorry.
So Mohammed asked the question whether there is about selective outcome reporting when all trials report the outcome. So as you see in this particular risk of bias assessment, all of the questions are all of the quality criteria actually that are listed or the quality criteria that are listed here are not including selective outcome reporting. What you see there is incomplete outcome data addressed. In other words, whether there is some loss to follow up, and whether all of the data is reported, rather than whether there is a concern about selective outcome reporting. So thanks for asking this question. I hope this clarifies. And I will go on and ask, yes, Dario to send the question to the chat room. I think that is easier than by voice. So the question is it hard to judge allocation concealment if it is hard to judge allocation concealment in some open or not blinded trials if they stated that they have proper allocation concealment. The Cochrane Handbook is not very clear about how to judge. Okay, and then why weighing? So why weighing of the studies is not included in the grade table? I go in order and I take Darius' question first. So weighing is in fact included indirectly. So number one, let me just say that one obviously discourages the weighing of studies on the basis of quality criteria because they this can lead to falsely large or smaller effects. So, but coming back to that, indirectly weighing is included. Now I will explain how. One point is that, for instance, if the study by Altenbus here in this particular example was a study that contributed 90% of all the data, and the study would this study would actually show a very large effect, while the rest of the 4 studies would be showing different results. Under those circumstances, one would obviously be much more concerned about saying, well, all of these studies show the same results, and therefore I'm not going to be concerned and I'm not going to downgrade. So there is an implicit weighting included as well. And the same is obviously true when we look at inconsistency of study results. So an implicit or a indirect weighting certainly is included here. And Mohammed repeated his question. My question was, when you have one outcome, say mortality, in 10 trials with data, how can you judge selective reporting bias when all included actually reported the outcome? Well, that's in this case, when you are setting out to answer a question such as this about mortality, and you identify all of the trials that are relevant for the particular question, and I should say that we would not obviously focus on when we search for studies on one particular outcome, and all of the trials that you identify dealing with the intervention of anticoagulation and mortality, when all of these trials actually report on the outcome mortality, it is very unlikely that there is selective outcome reporting bias. If you find another 5 studies, you find 15 studies that deal with the question of anticoagulation and cancer, and 5 of them do not report on mortality, but there is a hint or there is some information that would lead you to believe that mortality obviously is an outcome that would be addressed, then you are concerned about selective outcome reporting bias. So the straightforward answer is that if all studies that you identify report on the outcome and it looks like they report on it completely, then it's there is unlikely to be selective outcome reporting bias. Now, I will move on and I will ask participant 19 to keep the question for the end. I hope I will remember because I try to go in order with how the hands actually went up here. So let me move on. I will move on to going from the risk of bias to limitations in the design, and how the downgrading, what the guidelines for downgrading in the current handbook version are. So if we look at the left-hand side of this particular slide, the risk of bias here, if there's a low risk of bias, and that relates to the risk of bias across studies, so as you have just seen, it would mean that most information is from studies that are actually at low risk of bias or have a lot of green dots if we want to use the risk of bias table. The interpretation would be that all plausible bias is unlikely to seriously alter the results. In terms of considerations that one might have, there are no apparent limitations, and for a judgment about whether to downgrade or not to downgrade, the judgment could be no serious limitations, one would not downgrade. The The next situation is when there's unclear risk of bias, for instance, when most information is from studies that are at low or unclear risk of bias. Then the plausible biases may raise some doubt about the potential results. The interpretation, or the considerations rather, are that the potential limitations may be unlikely to lower the confidence in the estimate of the effect, because either these studies do not contribute a lot of events, or because the concerns were not very important, or the potential limitations are likely to lower your confidence in the estimate of the effect, and you may either consider this as having no serious limitations and not downgrade, or having serious limitations and downgrade by one level. And then finally, this is also from the handbook once again, you are concerned because most of the studies have a high risk of bias. The proportion of information from the studies at high risk of bias, therefore, is sufficient to affect the interpretation of results. And the plausible bias, therefore, seriously weakens the confidence in the results. And as a result, you may either downgrade by one level because of serious limitations, or downgrade by two levels because of very serious limitations. The important part here is that you should make your judgments transparent, because as we've seen from the first example, even experienced reviewers will make different judgments. I'll go on to the next example, and that has to do with inconsistency of results, or heterogeneity in the findings. It's the second criterion. If there's inconsistency, we would look for, if there's inconsistency, we would look for explanations, and in particular we would look for explanations in terms of whether there are differences in the patients, the interventions, or the outcomes between studies, leave alone methodological quality. Yet I would suspect that in many instances this may be resolved based on inclusion and exclusion criteria. In brief, if there is unexplained inconsistency, one would downgrade the quality of evidence. The judgments about inconsistency are in part common sense criteria, but obviously they are much more complicated when we think about how one can evaluate it methodologically. They have to do with a variation in the size of effect. They have to do with an overlapping confidence intervals. If you look at your forest plots, whether there is statistical significant heterogeneity, and we look, for instance, at the I-square. Now, the next slide actually shows you an example from one of these reviews that we did for in terms of treating patients with advanced cancer with anticoagulation agents, in this case vitamin K antagonists. 6 randomized trials. You see the actual point estimates and confidence intervals here on this forest plot, and although we don't encourage it for publication, I did order them by effect size here, going from the largest effect to the smallest effect, and you see that they range from a relative risk reduction of approximately 30% to a relative risk increase of about 20%, or a relative risk of 0.767 to a relative risk of about 1.24. And with fairly wide confidence intervals, all of them overlapping. Now, my question to you would be here, considering this particular example, who of you believes that there's important inconsistency, considering the 4 factors that I mentioned, the overlapping confidence intervals, and so on? Who believes there's important inconsistency rather than random error perhaps being responsible for this difference that you see? Okay, I'll go back to the forest plot. You may want to change your voting. Let me just be absolutely clear. Those of you who believe that there is important inconsistency, that is inconsistency that may not be explained by the randomness, should vote with a yes. And those who believe there is no important inconsistency, please vote using the B. Okay, and what I will do is I will ask Adrian to publish these results. So most of you actually thought that there was important inconsistency. I will invite one of you to tell me why they believe there is important inconsistency considering the 4 factors that I mentioned here. Okay, this is an interesting comment. Effect estimate showing both benefit and harm. Let me try to help you. Let me go back to these to the 4 criteria. I don't see listed differences in regards to studies and how they relate to benefits and harm. There is a variation in the size of effect, but there is a common, I think, misperception here, and that is that we are concerned about inconsistency or heterogeneity if studies show benefit and harm. The truth is we're concerned about inconsistency if they widely differ from the overall estimate of effect, or if they widely differ from each other. It is unrelated to whether there is actually benefit and harm involved. You can have inconsistency whether or not the point estimates indicate benefit and harm. And the most important point here is that we always should consider individual outcomes in the context of other outcomes. So for instance, we might be very concerned about inconsistency around a point estimate, a summary estimate of 0.6, because our threshold for using this particular intervention would be around the threshold of 0.6 for a relative risk. So once again, our judgment about inconsistency should be independent of whether we are seeing benefit and harms. It should be based on the actual summary estimate of effect. Okay. Then another point that was made is there is obviously overlap of confidence intervals, which would lead me to believe that most people this would be not a concern about heterogeneity, because if the confidence intervals overlap, then we would be not concerned about heterogeneity. So once again, let me try to explain this better. If we use these 4 criteria, and if we just think of this as random examples of studies, all of the confidence intervals here are overlapping. An important point. Therefore, any variation in the size of effect is most likely to be a result of chance. If we look at the actual I-square value, 0%, so unlikely to be, in terms of statistical testing, there's an indication that there is very little heterogeneity, if not none, and the p-value is not statistically significant. So in this instance, we would have said unlikely that there's important inconsistency. Okay, I'll show you another example, this time again ordered by magnitude of effect, ranging from the first study, a relative risk of 0.5, to the last study here, a relative risk of greater than 2. And I will ask you this question again. once again, looking at the 4 criteria, are the confidence intervals of all these studies overlapping? Is there a big variation in the size of effect that is unlikely due to chance? The I-square value shown here and the p-value. I will ask you again for a quick vote. Who believes there's important inconsistency? Say yes or no. Okay, and I will ask Adrian to publish the results. Some of you have not voted yet. That may be a result of us not having more time to wait. But this time you all believed that there was important inconsistency. So I hope that these 2 examples do in fact make it clearer. You all agreed that there was important inconsistency, likely because there is no overlapping confidence intervals for all studies, big variation in the size of effect that is unlikely to be explained by chance, high I-square, low p-value. Okay, I will move on. One question that we are frequently asked is should one downgrade for inconsistency when there's only one study? Well, the brief answer is if there's only one study and the search has been comprehensive, then there is no reason to downgrade for inconsistency, because there cannot be inconsistency if there is only one study. I go to the 3rd criterion, which is the directness of evidence. I will explain directness of evidence or applicability using the 2 key criteria that we are looking for. One is differences in the population, the intervention, or the outcome in regards to the question that we're actually asking and the evidence that we have identified. And I will separate this, or we separate this from indirect comparisons, and that has to do with we are interested in a comparison of intervention A versus B, but all the information that we find relates to intervention A being compared to, for instance, placebo, and intervention B being compared to placebo, in other words, C. All that we are left with is this indirect comparison of A versus B, in particular interesting for those who do network meta-analysis, how to judge that. As an example, we have 3 interventions we would like to compare for formoterol versus tiotropium, but they only have been compared against salmeterol. So the indirect comparison of interventions is of concern, and of concern is if the population, the intervention, or the outcome is importantly different in the evidence that we identify compared to what we have been interested in. I'll give you a few quick examples for that. So the indirect comparison, as a further example, if the question of interest is early emergency department systemic corticosteroids to treat acute exacerbations of adult patients with asthma in comparison to and we are interested in comparing oral versus intravenous routes. We find evidence that both are effective, but there is no direct comparison of these 2 routes of administration in adults, actually, and this would leave us with important concern because of the limitations of indirect comparisons that we know of. The next criterion has to do with differences in the population that we're interested in from the one that has been enrolled in the studies that we're interested in. So, for instance, the question of interest may be once again in asthma, anti-leukotrienes plus inhaled glucocorticosteroids versus inhaled glucocorticosteroids alone to prevent asthma exacerbations and nighttime symptoms in patients with chronic asthma and allergic rhinitis. The trials that actually measured asthma exacerbations and nighttime symptoms did not include patients who had both asthma and allergic rhinitis. So the question is whether we can generalize the results from a patient group with only asthma to those who have asthma and allergic rhinitis. In most instances, there would be little concern about this particular generalization, and therefore one would not downgrade the quality of evidence. The 3rd criterion is differences in the intervention. So if we were interested in public health measures that would look at whether the avoidance of pet allergens in non-allergic infants or preschool children prevent the development of allergy, and we would be looking for the randomized trials, we would find one randomized trial that actually used a multifaceted intervention that combined the avoidance of PET with a number of hygienic measures, therefore we would be left with uncertainty whether we can make judgments about the single intervention PET allergen avoidance and its effect on allergy development because it has been part of a multifaceted intervention. So there's a difference in the intervention that we are interested in, PET allergen avoidance, from what we identify in terms of evidence, which is PET allergen avoidance as part of a multifaceted intervention. This is an issue around directness, and we might downgrade the quality of evidence for that particular reason. Finally, difference in the outcome of interest compared to the actual outcome that we are interested in obtaining information about is different from that we identify in the trials. Once again, similar example, intranasal glucocorticosteroids versus oral H1 antihistamines in children with seasonal allergic rhinitis. We are interested in measuring quality of life in these children, but in the available studies, the quality of life was actually rated by the parents. It was indirectly rated instead of the children or teenagers that we are interested in ourselves. A similar example relates to if we're interested in the outcome mortality, and all that we find, you are all familiar with that, all that we find are surrogate measures of mortality, such as blood pressure or cholesterol levels, etc. Okay, are there questions about indirectness? I will be taking one question about indirectness, and you can just type it in the chat room. Okay, let me move on. If there are no questions, the fourth criterion is publication bias. I will move through this relatively quickly. Most of you will be familiar with that. We are always concerned about publication bias. We are particularly concerned if there's a number of small studies and if all or most of these studies are actually indicating treatment effects, or large effects in particular. Just quickly, this is a very well-known example, the use of intravenous magnesium in acute myocardial infarction. A meta-analysis by Yusuf and colleagues in 1993 indicated that magnesium led to about a 20% relative risk reduction for mortality if patients received it right after myocardial infarction. Now, when this meta-analysis was done, there was obviously concern that there were a lot of smaller studies indicated here by the dots at the lower end of the y-axis, a lot of smaller studies that showed very large estimates of effect. In particular, once again, emphasized by the very small studies. Now, then when a large trial was actually done, the ISIS trial with over about 50,000 participants, this trial actually indicated no effect. If we take the odds ratio to be similar to the relative risk, actually no a relative risk or odds ratio close to 1. And what is the reason behind that? Why did this meta-analysis by Yusuf and colleagues before ISIS-4 indicate this large effect? Well, it has to do with publication bias. Quickly explained, we use some funnel plots to explore as one of the reasons, one of the methods to explore publication bias, where the size of the study is represented on the y-axis here in an inverse relationship, or inversely plotted, and the magnitude of an effect of each individual study here on the x-axis. Each dot represents the estimate of effect for an individual study. The further down the plot is on the y-axis, once again, the smaller the study, the further up it is, the larger the study. What we typically would see is a symmetrical distribution, therefore inverted funnel, called inverted funnel of the individual study results around the best estimate of effect here in odds ratio of 1. What happens is In this particular case, this looks symmetrical. There would be no publication bias. What, however, frequently happens is that studies that don't confirm the hypothesis of the authors, such as those that indicate negative results, are either not published or journals have no interest in publishing it. And that makes the funnel plot asymmetrical, indicator for publication bias. What happens next is if you then would do a meta-analysis, the estimates of effect may be significantly shifted, in particular indicating larger effects than in reality exists. So here the odds ratio might move from 1 to 0.6 in this particular example. I will address one other question that has to do how do we assess publication bias if there's only one study? Well, I can tell you if there's only one study, there is very likely to be other risk of bias involved. So that if a field is poorly explored, there is likely to be study limitations in this one study, and there's likely to be imprecision, that there would be downgrading for other reasons as well. One is always concerned about publication bias, but obviously less concerned when a systematic search is conducted, and one in particular goes into assessing other sources of evidence. A single study alone, however, is not a reason to downgrade. Imprecision is the fifth criterion, has to do with small sample sizes, or if they're in particular wide confidence intervals. The extent to which one can be confident in an estimate of effect and how adequate it is to support a decision should be the guiding principle for judging imprecision. I'll provide you with an example. So this is a review looking at an antibiotic and prophylaxis in patients who have low white blood cell counts, and looking at the outcome in infection-related mortality. So despite many studies having addressed this question, more than 10 studies having addressed the question, and despite over 1,000 patients being enrolled in these randomized trials, there were only 49 events, 14 in the antibiotic group and 33 in the placebo group. And although it's indicating a large estimate of a large effect with a relative risk here of 0.38, one might have important concerns about precision here, or how confident we can be in this actual estimate of effect 0.38, because there were only 47 events in these particular trials. So despite a large sample size, small numbers of events can leave us with important concerns about imprecision, and it obviously is a judgment in terms of how important this imprecision is, and whether one should downgrade. I give you another example. More than or nearly 10,000 patients randomized in studies that looked at bleeding in patients who were thromboprophylaxed in the hospital. And once again, despite almost 10,000 patients randomized, only 44 events, leaving us with a confidence, with a point estimate that is accompanied by insignificant confidence intervals, which may lead us to downgrade the quality of evidence. Okay, what can raise the quality of evidence? A large magnitude of effect can upgrade the quality of evidence. Very large magnitude of effect can upgrade by 2 levels. A large magnitude of effect is, for instance, a relative risk reduction of 50%, and we use as a guiding principle a relative risk reduction of 80% for a very large effect. If we think about example, oral anticoagulation for mechanical heart valves is one example, insulin for diabetic ketoacidosis, hip replacement for severe osteoarthritis, and those of you who are familiar with the parachute example in the BMJ, parachutes to prevent the death when jumping or falling from airplanes, this would come with a very large estimate of effect, and it would increase our confidence that an effect is actually present. All of these criteria that I mentioned here for upgrading primarily apply to observational studies. The second criterion is a dose-response relationship. A good example is the more blood thinning is involved when we look at blood thinning interventions, the higher is the INR, and the higher is the increased risk of bleeding, where the INR is a measure of blood thinning. So there's a dose-response relationship between how much anticoagulant we give and how much bleeding there is. Another example from observational studies is in the past, children frequently who suffer from lymphoblastic leukemia have received cranial irradiation to prevent recurrence. Now, when investigators have looked at the risk of CNS, secondary central nervous system malignancies, a long time after this cranial irradiation, 15 years later, they found that those who had received no irradiation had a 1% risk of secondary CNS malignancies. Those who had received 12 gray of irradiation, a 1.6% risk of secondary malignancies, and those who had received an even higher dose, a risk of 3.3%. This indicates dose-response relationship and may lead to upgrading the quality of evidence. Finally, the criterion is whether all plausible confounding might have resulted in an underestimate of the treatment effect. We use a classic example that is also in the Cochrane Handbook. So when we did a systematic review looking at death rates in private for-profit versus private non-for-profit hospitals, we found that there were higher death rates in private for-profit hospitals, and this happened despite the fact that patients in the non-for-profit hospitals were likely to be sicker than those in for-profit hospitals. That would have led to the opposite result, and for-profit hospitals are likely to admit a larger proportion of well-insured patients than not-for-profit hospitals, and thus have more resources with a spillover effect. Similarly, in the opposite direction, all plausible confounding would result in an overestimate of effect. The hypoglycemic drug fenformin has been surmised as causing lactic acidosis, an important liver complication. A related agent that many of you will be familiar with, metformin, has been under suspicion for the same toxicity. Large observational studies, however, have failed to demonstrate this association, and that took place. So they failed to demonstrate an association, despite the fact that clinicians were very aware of this potential complication and more alert and likely to over-report the complication lactic acidosis in the presence of the use of metformin. Now, I have explained to you or presented to you the quality criteria that are applied when using GRADE to assess the quality of evidence for a given healthcare question. I will go to my summary slides and make sure that we have a little bit of time for discussion here. So the summary slide is that the quality assessment takes place as follows. Randomized trials start as high quality, observational studies as low quality. We lower the quality of evidence for the 5 criteria that I explained, and we increase the quality of evidence for the 3 criteria that I mentioned there. And it is important to be reminded that one needs to carefully consider and assess all the factors that may influence the quality of evidence, and to bear in mind that down and upgrading for specific quality criteria should be done in the context of all the factors that influence the quality of evidence. Downgrading for one quality criterion may influence how the next quality criterion is actually dealt with. The quality assessment happens obviously within and across categories. We downgrade or upgrade on a continuum. Everything else would be wrong to say, but we use categories in order to communicate information. We downgrade or upgrade within each category, and we keep in mind the decisions or judgments that we have made in other categories. I go to my summary slides. So in summary, when we use GRADE to assess the quality of evidence, there are 4 categories for the quality of evidence. The evidence is assessed by outcomes, by outcome, 5 factors lower the quality, 3 factors increase the quality. Judgments are involved. What is important for Cochrane systematic reviews or systematic reviews in general is to make the judgments transparent. And in particular, when we speak about summary of findings tables, we need to make sure that any judgments are explained in footnotes or in the text. I'll stop here, and there are a couple of questions. Please submit your questions through the chat room. So one of the questions is, can heterogeneity between studies also affect precision? If yes, that's penalizing twice for the same limitation in evidence. So can heterogeneity between studies also affect precision? Well, it is unlikely, in fact, to identify important heterogeneity if there is imprecision. In other words, if there are few events, few studies, or few participants, it is unlikely to detect important inconsistency, so that one would unlikely downgrade for imprecision, for inconsistency, and then again for imprecision. One would be likely to downgrade for imprecision, but not for inconsistency in that sense. There is a question of whether you can have my slides. The slides will be available. Yes. A question was raised, what is the right answer to the second exercise when we answered 50-50? This raises the issue of that you need to be transparent about your judgments. It is perfectly fine to disagree on these judgments. Two reviewers need to come to an agreement and describe why they upgraded or downgraded, but it emphasizes the importance in regards to being transparent about the judgments and listing them in the footnotes or explaining them in the text. I can also tell you by experience, obviously this was a very brief exercise here, by experience that with additional training these judgments become more and more consistent, in that you answered, there was a 50-50 split when I asked the question about whether you believed there was important inconsistency, and at least one of you thought that because some studies indicated benefit, other studies indicated no benefit, that was a reason to be concerned about the inconsistency. I think with the clarification that I've given, these judgments would become more consistent. And are there any other questions? Then let me go back, because I believe that we potentially have another minute. I have, at least Adrian, I have not seen my 5-minute timer. Perhaps that should come up at some point. But anyway, I will go to participant 19 and the question that it is hard to judge allocation concealment in non-blinded trials when they have properly, when they state that they have properly concealed allocation concealment. So I'm not sure whether I understand the question completely, but if the systematic reviewer, on the basis of what is presented in the individual studies, believes that allocation concealment has been done properly, then this obviously is the judgment about allocation concealment. Now, what I think the concern about whether a study is not blinded is a separate concern, in that you would obviously be, despite the presence of allocation concealment, be concerned that there may be a risk of bias if the outcome, for instance, was assessed in non-blinded fashion. But at the same time, what is critical is that in particular in unblinded studies, allocation concealment should take place. And perhaps that's what the question relates to, that there is an interrelation between allocation concealment and blinding. One question that is raised before I finish: how many people should weigh in when using grade? The brief suggestion is that like you would do a systematic review and perhaps assess abstracts in duplicate, it would be ideal if at least teams of two appropriately trained reviewers would do the quality assessment and would make the judgments, first of all, resolve any disagreement and make the judgments transparent by explaining them either in the footnotes where the quality assessment takes place or in the actual text. I'm being reminded to finish. I think the 1 hour is over, and I will hand the microphone back to Adrian. Thank you very much for your attention.
Well, thank you very much, Holger, and I am in accordance with my colleagues here. Thank you for this great presentation. We appreciate your time, Holger, and your expertise. Folks, before you go, I do want to send you an evaluation form for today's session. We value your input if you have any feedback. In particular, if you have any ideas for topics that we can host in future webinar series or any feedback on the use of Illuminate, I would be glad to receive it. I'm going to send that through to you now. And as Holger mentioned, we are happy to provide today's slides. If you could email us at ccnc-iph@uottawa.ca, then we will be happy to provide those for you. Again, thank you very much for your participation. You've been a great crowd getting involved in the polling, as well as in the discussion and in the chat room. We very much appreciate you. We look forward to seeing you again in future topics of this webinar series. Have a great day.